Dr. Jalal Ahmed. He graduated and did his postgraduate all from India in nephrology. He's acting as a specialist nephrologist at Sultan Qaboos Hospital and as a consultant nephrologist at Victor Hospital in Goa. And he's going to cover the topic of kidney disease of unknown origin.
Assalamu alaikum, everyone. I will be speaking about CKDu, that is CKD of unknown origin, which remains a mystery in nephrology. Coming to the definition of CKD, CKD is defined as, we all know this, that it is kidney damage, either structural or functional, which is lasting for more than 3 or more months, which is defined by GFR, and irrespective of the cause. So in CKD, we have the ones where the cause is known, the one where the cause is not known. The one where cause is not known is called CKDu, CKD of unknown origin. So the common causes are, as we know, diabetes, hypertension, obesity, and global nephritis. The one which we don't know is CKDu. Where the cause is not known, it is called CKDu. So it is not that we do not know anything about CKDu. We know few things, that some risk factors are common among the people who get CKDu. So CKDu is a type of CKD which mainly affects marginalized agricultural communities. They live in a low-lying area where the heat stress is more, and there are occupational and environmental hazards. So it develops in specific endemic regions, and it has become an epidemic over the last century. So coming to the story of CKDu, it started in 1912. It was recognized then, where the people residing near Jinzu River in Japan, they presented with bone pain, muscle weakness, and kidney failure. So there was a lot of studies done. Finally, the culprit was found to be cadmium, which was found in the soil, rice, and various, even in the water which they drink. So it took a long time from 1912, and the discovery was done in 1968. The Japanese ministry, they found out that the chronic cadmium exposure is causing the disease. Then it came to be known as itai disease. That means, it's painful, och. So the CKDu became something known. It became itai disease. We know that cadmium is causing the kidney disease through causing interstitial nephritis. So it took a long time to define the cause. So, and for cadmium, there is no specific therapy. It is only supportive therapy. No chelating agent has been found until now. And supportive and renal replacement therapy remains the mainstay. But after that, the Japanese government has taken measures, and now the exposure is less, and the disease incidence also has reduced a lot. So coming to the CKDu, how it, in 1912, it was in Japan, it was discovered, and then in 1956, in the Balkan states are the ones which are near Europe, Romania, Yugoslavia, Serbia. Serbia, they also started having unexplained kidney disease. I'll come to that now. And later, more recently, in 1990s, we discovered the kidney disease in Sri Lanka and Central America, Mesoamerica, and in India. These are the predominant regions, and multiple other places. So among these, only the Japan and the Balkan endemic nephropathy, they have been solved. The etiological agent has been found, but rest of them still under process. So these are the predominant regions which I mentioned just now. One is aristocolic acid nephropathy, that is in China, Taiwan, and Belgium. Balkan is in Balkan states. Mesoamerican is in the Latin Central America. And Sri Lankan nephropathy, and in India, many places in India. This is the map from ISN which shows the same. You can see that you can see that the Latin, the Mesoamerica, the part which is next to United States, and the Europe has this Balkan nephropathy. India has Uddanam nephropathy, and Sri Lanka is also severely affected by CKDu. In Japan, there is itai. So Balkan, coming to Balkan nephropathy, it was first recognized in 1950s, and in 1969, Lajek proposed that the seeds from Aristolochia clematitis might be the cause. But still, it took again 24 years to realize that this herb, which is taken for slimming, as slimming remedies, is the culprit which is causing interstitial nephritis. So basically, it causes interstitial nephritis in kidney, and also it causes aristolochic acid DNA adducts, and it has capacity. It causes uroepithelial malignancies, and these were found in the people who were living in Balkan region. So this is how it causes the adducts, and then mutation in TP53 causing malignancy. It also damages tubules, causing Fanconi syndrome. So they presented with typical features of tubulointerstitial nephritis, something like fever, loin pain, some dysuria, and even the lab features were suggestive of interstitial nephritis. And basically later they realized, and the exposure was reduced, so the incidence came down. And in aristolochic acid nephropathy, the corticosteroid therapy, as we know for interstitial nephritis, we use steroid therapy, and it has been proved to be beneficial. The same is happening with aristolochic acid. If we recognize it early, then it can be treated with corticosteroids, but if it is late, it is, we'll have to just manage the way CKD is managed. So coming to Mesoamerican nephropathy, this is in 90s. It was discovered that in the hospitals in the Latin America, Central America and Latin America, a lot of young sugarcane workers were coming with unexplained kidney disease. So the upsurge was also seen in El Salvador and many other countries in Latin America. And it became so grave that the hospitalizations for CKD in Salvador increased by around 50% between 2005 to 2012, making CKD the largest cause of hospitalization for the country, and a lot of huge economic burden too. So they came with the typical symptoms of interstitial nephritis again: dysuria, frequency, urgency, chills, and flank pain. Collectively, according to the local terminology, they call it as chistata. Similar features for interstitial nephritis, and they were often misdiagnosed and treated with the antibiotics and the aminoglycoside, worsening the problem. So creatinine used to rise indolently, and persons they used to present as ESRD. So predominantly it affects male people who work in the fields. The incidence is more among men, and they come with the features of tubulointerstitial nephritis, and when the biopsy is done, it also shows features of tubulointerstitial nephritis with the infiltration of lymphocytic infiltrate and interstitial fibrosis. So what are the possible causes? We are still, the Mesoamerican nephropathy, the cause is not yet found. The proposed mechanisms are that the heat which is there in the low altitude regions, they cause dehydration, then it causes hyperosmolarity, which causes activation of vasopressin and aldose reductase pathways, and then the interstitial and glomerular damage. And heat stress also causes rhabdomyolysis, that can also cause. But heat stress by itself does not cause the disease. As we see in many Gulf countries, also there is not much of CKDu. And so the other inciting agent, they have been looked into. Most of these places, they are looking into toxins, pesticides, heavy metals, whether these are the culprits in causing this kidney disease. And some infections can also cause interstitial nephritis. So there is intensive research going on to find out the same. So this is again the pathophysiological mechanism. of how the heat stress can cause the kidney disease. It causes dehydration, the osmolality increases, it causes activation of aldose reductase pathway, and there is hyperuricosuria, there is ischemia and endothelial dysfunction, glomerular hypertension, and oxidative stress and tubular interstitial damage. Activation of RAS also through the same, and up to some extent rhabdomyolysis also can cause the damage. But heat stress by itself cannot cause the disease, so they are looking into multiple factors which could be the inciting agent. And most of the times all these unexplained disease happens in agricultural population. So these agrochemicals, pesticides have been looked into as whether they are causing the disease. So this is a figure depicting the same agricultural population. There is heat stress and exposure to agrochemicals, environmental hazards. This is the same again, heat. These are the risk factors which can cause Mesoamerican nephropathy, heat and dehydration, pesticides. Like glyphosate, it has been shown to, some studies have shown that this may be the culprit in Sri Lankan CKDu. And heavy metals also have been studied. And infections can also cause, once they have the episode of leptospira, they can continue as subclinically as chronic interstitial nephritis. NSAIDs, the consumption of NSAIDs and tobacco smoking can aggravate this problem. And other than that, because it happens in specific regions, even the genetics have been implicated that that may also play a role in causing these diseases. There is familiar clustering in these diseases among the families. Among the families, there is more incidence of kidney disease. So there have been many genes have been implicated. In Sri Lanka, there is Sri Lankan CKDu KCNA10 gene, which is a voltage-gated potassium channel in the proximal tubule. Mutation in these genes have been implicated, and Indian CKDu CYP1A1 gene has been implicated. And some of the cases have been implicated to be ADTKD because they also present subclinically. So the other major region where the CKDu is predominant is Sri Lanka. The incidence of CKDu is around 17 to 20% in Sri Lanka. It has been a huge burden for the government too. So again, the symptoms are similar to dysuria, back pain, and sterile urine, and most of them are asymptomatic. So in the Sri Lankan, in the studies done in Sri Lanka, field work more than 6 hours per day, sun exposure, consumption of less than 3 liters of water per day, and history of malaria have been proposed as risk factors for developing CKDu. And agrochemicals, the glyphosate has also been implicated. In India, since 2005, there was a registry which was established to find out the etiology of kidney diseases, and it found that after diabetes mellitus, CKDu is the second second most common cause of CKDu in India. And later, multiple spots of CKDu region were discovered, reported actually. It was going on since quite some time. When biopsied, most of the times they reveal interstitial fibrosis, and they also have the similar risk factors like Mesoamerican nephropathy, heat stress, agrochemicals, agricultural population. These are the places in India where CKDu is predominant. This is my personal exposure to CKDu, the place where I used to work. I used to visit this health center also. This is a small village. There is a small health center. Even in this small health center, there are 30 dialysis machines, which is continuously running 3 shifts. So it causes a lot of economic burden for the government also. So right now, according to latest studies, around 35 countries have reported incidence of CKDu. I mean, not as severe as India, Sri Lanka, or Latin America, but in significant proportions. Even in Egypt, Tunisia, there are places where CKDu is predominant. So this is a criteria. Basically, we have to rule out other causes, like other regular causes, diabetes and other structural causes. And through kidney biopsy, it will be confirmed when it shows interstitial nephritis. And this is a summary where the first two, the etiology has been confirmed. The the cadmium exposure is the cause. And Balkan nephropathy, aristolochia dermatitis is the cause. But the latest ones, since Mesoamerican nephropathy, Sri Lankan CKDu and Indian CKDu, the prime inciting agent we have not found yet. Yes, yes. So prevention and management is basically through interventions by the government where they provided acclimatization, rest and shade and water and electrolyte solutions, and it was found to improve the AKI. This was done in Nicaragua in Latin America, and similarly in Sri Lanka also they provided water, rest, shade program and clean drinking waters, which improved the results. So other preventive methods are the same as avoid exposure to the pesticides, probable pesticides, and health education, and provide social welfare support. As a nephrologist, what we can do is recognize the disease initially and avoid the risk factors, keep them well hydrated, avoid ask them to avoid any extreme heat exposure, avoid MSAIDs, and if it is in the initial stage, if it is in biopsy them, if there is interstitial nephritis, probably we can treat them with steroids. The place where I used to work, there used to be a lot of people who come with interstitial nephritis with no inciting agent. We used to treat them with steroids and they used to get better. But if they come at the later stages, the only thing we can do is to treat them as a normal chronic kidney disease. Thank you.
May I ask all the other speakers please to join us on the stage? Dr. Bassam, Dr. Ali, Dr. Shayma, and Dr. Halal. The floor is open.